Okay, looks like we're gonna go with our second virtual class again. Hope everything's going well with you guys, and I hope you're able to access the class we had yesterday. And please let me know if you have any questions. Send me an email. But I think it's pretty straightforward, so we're gonna get going with the second half of this chapter. We left off last time. We talked about the anatomy and preventing ankle injuries, and talked about assessing the injuries. And our first injury, ankle sprains, are three different types: inversion, eversion, and also high ankle sprains, and then how to take care of them. So we're going to move right along and start talking about ankle fractures. So cause of the injury, they can occur from several different mechanisms, so it's kind of hard to sort of zero in on one. A lot of times you have some sort of ankle sprain, maybe going to a further extreme that causes the bone to fracture, so kind of a lot of different mechanisms can occur. Signs of the injury, so fracture of either the malleolus, which is the distal or distal end of either the tibia or the fibula, usually results in immediate swelling. And a lot of times with any fracture of any bone really in the body, it's going to be kind of like direct point tenderness at the spot. Like this has a lot of swelling. Care of them, if it's possible if the possibility of fracture exists, you should splint the area, and the athlete should be referred for an X-ray and further immobilization. Once they're near normal levels of strength, flexibility, and neuromuscular control, they have been regained, the injured athlete can perform functional activities. They may resume their normal activities. And in a lot of cases with some of these fractures, they may even need surgery because you want to make sure the joint is going to heal as close to normal as possible. Tendinitis, cause of the injury. There's not necessarily a singular cause. It's usually a collection of mechanisms. Improper footwear may create faulty foot mechanics. There could be some trauma to the area or tightness or training errors. So signs of the injury: pain with both active movement and passive stretching. So active movement means you just move it normally and it hurts. Passive stretching means that someone else is stretching you, so a lot of times you'll have also pain with that. Swelling around the area of the tendon, possibly caused by the inflammation of the tendon. You may hear that crepitus we talked about in the last class, where you have that creaking like a door opening, and stiffness and pain following periods of inactivity, but particularly in the morning. And when we say tendonitis, we talk about a lot of different things, and we'll talk a little bit more specifically about Achilles tendonitis, but really tendons, have lots of tendons in the foot that can have tendonitis occur in them. Care of them, you want to help in the healing of them through rest modalities like ice. Anti-inflammatories should also be used, and especially with the foot, we have the use of orthotic devices that can correct the biomechanics, or taping the foot like we've learned in class, to reduce the stress on the tendons. Okay, so we kind of hit the ankle injuries. Now we're going to move into lower leg. So just to kind of go back now a step to our assessment, some different things we want to focus on for assessing the lower leg. First, in our history, how long has it been hurting? So a lot of times you're going to have this prolonged lower leg pain, a lot of times associated with shin splints. So we want to make sure we ask those questions because we want to make sure we don't miss that extended pain in the lower leg, which can kind of make you think about possibilities of stress fractures in the lower leg. We want to kind of hone in on the pain and discomfort where it is. As with any injury, But specifically in the lower leg, what we're looking for is it more on the bone? Is it soft tissue? Because that can make a big difference in sort of where we go from here. Has the feeling changed, or is there numbness? Okay, that will kind of move us towards, was it a certain kind of pain at first, and then it sort of changed over time, and that numbness, we will start to worry a little bit about compartment syndrome, and we'll talk about that as one of our lower leg injuries. So that's an important thing to know. Is there a feeling of warmth? Can be indicative of, again, a compartment syndrome or an inflammation or a infection of the lower leg. Is there any sense of muscle weakness or difficulty in walking? That can be due to, again, a compartment syndrome. Difficulty walking can be kind of any injury, but definitely want to know if they're just even if they're having difficulty walking, something significant's going on. And then how did the problem occur? Was it more of a traumatic injury, or has it kind of progressed over time and become worse and as like a chronic injury? Observation, going to generally observe the athlete. Any postural deviation such as toeing in or should be noted. Any walking difficulty should be noted, along with leg deformities or swelling. Also might be a good time to look at them walk like we kind of did with the foot, because a lot of things that occur in the foot can affect lower leg soreness and pain, and kind of leads directly to having shin splints. Palpation and special tests. Palpation should be done over the musculature in each of the 4 compartments. So we didn't really talk about the compartments, kind of a little higher level anatomy, but basically the lower leg is kind of split into 4 different compartments: the anterior, the posterior, anterior, lateral, and then there's 2 posterior compartments, a deep and a superficial. So anterior is in the front, lateral is on the outside, and the 2 posterior in the back of the lower leg. And we'll talk about what can happen in those areas, but basically those areas are kind of confined by soft tissue, so they really truly are compartments with almost like walls that kind of keep all the structures in that area. And we're talking about muscles, we're talking about tendons, we're talking about blood flow through veins and arteries. So a lot of stuff going through there. And when everything's working well, it's fine. But when you get inflammation or swelling in those compartments, then we get worried about cutting off that blood supply, and that becomes a problem. So you want to make sure that you're palpating in each of those different compartments of the lower leg to assess where exactly the pain is. Special test, the Thompson test. It's a pretty simple one. It determines if there's an Achilles tendon rupture. You're just going to squeeze the calf muscle, and you're just looking for the foot to extend. So you can kind of try that on yourself. Just pick your foot up off the ground, grab your calf and squeeze it, and if everything's normal, your foot should kind of point down to the ground, and basically which is plantar flexion, which we've learned before. Okay, getting into some of the specific injuries of the lower leg. Tibial and fibular fractures. So basically what's the cause of the injury? We're usually a direct blow or indirect trauma to the bone. So a lot of times direct blows, you'll have injuries that are more centralized to the middle or upper portion of the bone, and a lot of times indirect trauma kind of related to ankle injuries can cause fractures down towards the ankle. Fibular fractures are seen with tibial fractures as a result of direct trauma. So a lot of times if that's pretty significant direct trauma to the lower leg, both of those bones could fracture, and that's obviously a pretty significant injury. With tibial fractures, you're going to have pain, swelling, and a possible deformity. It could be open or closed. Fibular fractures are usually closed, present with pain and point tenderness on palpation and walking. So if you think back to our anatomy, the tibia is a much larger bone. If that fibula fractures, it's very well splinted because of that tibia, and it's less likely to come through the skin. With a tibial fracture, it's a main weight-bearing bone of the lower leg, so a lot more significance with that injury. So definitely, that's kind of a little bit more of a medical emergency in that case. Care of these fractures, immediate treatment should include splinting, immobilizing the fracture along with ice, followed by immediate medical referral. Obviously, no weight bearing for weeks or possibly months, depending on the severity. And obviously, surgery may be necessary in these cases because, you have to have actually good healing, and a lot of times good healing won't occur if you don't have a clean fracture that will come back together easily. Now we talk about stress fractures. So actual fractures we just talked about, those are acute, a direct hit or indirect trauma to the area. A stress fracture is something that kind of comes on over time because of repetitive loading due to training and conditioning. Attributed to shoes, faulty foot or ankle mechanics, or both of which can be easily dealt with. But a lot of times when I talked about like how long has the lower leg pain been occurring, when we have situations where an athlete may say, yeah, it's been hurting for a few weeks, I took some time off, it felt a little better, then it got worse again. A lot of times if we don't nip that in the bud early on, it can progress into a stress fracture. Signs of the injury, you have pain with activity that sometimes becomes worse when the activity is stopped. Okay, so it's kind of a big kind of flashing light. If you're having shin splints, on all likelihood when you stop, it should get better. It may not go away completely, but it should get better. If you have pain that gets worse when activity stops, then you're like kind of has a flashing light going off saying, hey, we may have a stress fracture here. You're going to have focal point tenderness on the bone, helps determine a stress fracture from a medial tibial stress syndrome. And medial tibial stress syndrome is more of a shin splint. Stress fracture, obviously, stress fracture. So if we, again, that's why we ask, can you point to one place where the pain is? If the athlete's able to point to that one spot where the, where the pain is, a lot of times we really focus in on that being a stress fracture. If they have a hard time localizing that pain, then we kind of are leaning more towards a straight up shin splint. Okay, care for these. An athlete with a suspected stress fracture should be referred to a physician for diagnosis. Recuperation for a 2-week period in which the athlete can continue to be weight bearing but must not engage in activity. So a lot of times they may be in a boot for this period of time, depending on where the fracture is. And will be weight bearing but have limited weight bearing time because of the boot. In some cases, I've seen athletes who are non-weight bearing at all on crutches, and it may be even longer than 2 weeks. So it's kind of varying depending on the significance of the injury. Okay, shin splints are what's more technically called medial tibial stress syndrome. So a lot of times because of we see this a lot of times in running sports. We have that irritation of the lower leg. A lot of times it's that connection between the tibia and the soft tissue of the lower leg, and you get that medial tibial stress syndrome. We have increasing pain specifically at the distal 2/3 of the posterior medial aspect of the tibia. So basically really can happen anywhere along the tibia. And you want to be concerned about stress fractures, compartment syndromes, tendinitises, can all result in this pain. So, we don't just chalk it up to shin splints all the time. We want to make sure we rule out those other things. And we'll talk specifically, we've already talked about stress fractures, but we'll talk about compartment syndrome to kind of differentiate between those things. Pain is usually diffuse about the distal medial tibia and the surrounding soft tissue. So when I say diffuse, it's not specific, it's not pinpointed, it's all over. So that's one key that it's probably more shin splints than stress fracture at least. As the condition worsens, daily walking may be painful, and morning pain and stiffness may also be present. So now we're kind of progressing from the shin splint towards a stress fracture if it's not treated properly. Care of it, the patient needs to be Refer to a physician, ruling out the possibility of stress fracture. You're going to use bone scans for that. And they also use x-rays. They kind of go x-ray first, bone scan after that. Activity modification. So what I usually tell people, and it's usually, again, we're dealing with runners, we want to make sure that we use rest. So we try to strategically use rest between their races, maybe take a race or two off. But rest is the best policy for these things. And then obviously we want to try to correct their abnormal foot mechanics. So if we find they have a flat foot or a high arch that's causing them problems, or their shoe's an issue, or maybe they have some tightness in their Achilles complex, we want to work on those things and work with ice massage, usually with an ice cup or some kind of icing device that will allow us to roll over the area. So we can massage it along with icing it. We usually do that. Shin contusions, okay. Basically, like any other contusion in the body, the area gets hit. It's obviously vulnerable in a lot of different sports. And if you feel on your own leg, you can feel that the tibia is pretty close to the skin. And it is pretty painful. So a lot of times when you're getting that contusion, it's not as much soft tissue as it is really a bone contusion. You're going to see increased pain, swelling, and warmth in the area. Hematomas are very common in this case. Basically, it's a blood tumor, and I know that sounds awful. You automatically think about cancer, but you get that hit to the bone. It bleeds a little bit, and over time, it kind of gains a little bit of a outer layer to it and kind of causes it to be confined to one spot and looks kind of like a golf ball. I once had a soccer player with one of those, and he didn't really follow our guidelines very well and kind of had a permanent lump on his shin. So a lot of times we get hit in the shin, we think it's no big deal, it just bruises up, but we really need to make sure we're putting some compression on it, elevating, icing it, protecting it with maybe a donut pad or like a shin guard to protect it so it's not getting repeatedly hit, and try to help to have that swelling go down and not kind of be chronic swelling that sticks in there for a while. Okay, compartment syndromes. Probably the most significant lower leg injury that we'll deal with. We have increased pressure within one of the 4 compartments of the lower leg, causes compression of musculature and neurovascular structures within the compartment. I talked about there's muscles in those areas, tendons, blood vessels, and arteries, and I forgot to mention there's also nerves in those areas. So we're cutting off blood supply and nerves. That's a problem for our foot. So this is a very important situation to be dealing with. So signs of the injury, you're going to have increased intercompartmental pressure associated with compartment syndrome, so it's going to lead to a deep aching pain, tightness, and swelling in the area. And a lot of times, obviously, with reduced circulation and sensory changes will affect the foot. You may also look at the leg, and it almost looks like kind of a wood consistency, so sort of the texture of the skin changes because it becomes so tight. It looks very rigid instead of kind of more pliable like our skin normally looks. Alright, so how do we take care of these injuries? They're kind of dicey to deal with at first, or over time. But at first we're just taking care of it with ice and elevation. It's really not something you're going to, right off the bat, you're probably going to have a progression of thought process with these. First you're probably going to say, okay, maybe it's a shin splint or a calf strain. And maybe you progress to thinking, well, maybe this is a stress fracture. And then you start to hear things like, pain, having a funny feeling in their foot, like they're going numb, or they feel like they're losing blood supply or something like that. Then that's where you kind of get to the compartment syndrome. So you're probably not going to immediately say, right off the bat, it's in a compartment syndrome. It's probably going to progress over time, unless you have an acute compartment syndrome where you have an injury to the lower leg, like a fracture, and you have immediate intercompartmental pressure that increases. When you have acute compartment syndrome or acute exertional compartment syndrome, that's a medical emergency. Surgery is going to be performed very quickly to release the pressure. So basically they're just going to make an incision along the lower leg in that compartment to sort of open that up and release the pressure. Surgical procedure for anterior deep compartment syndrome, and it may require 2 to 4 months post-surgery, so it is a pretty significant surgery. It's not like they just open it up and we're good to go. It's a lot of times, sometimes dealing with infection down the road or something like that. It's very open to that because sometimes they'll leave the incision open, allow it to sort of the pressure to go down. So it's kind of important to see these things early on and deal with them. There is conservative management of chronic compartment syndrome, which means this kind of progresses over time. Maybe you can modify their activities, do icing and stretching, which can help. But you want to make sure that you always be aware of the fact that conservative measures could fail and we may have to have surgery performed anyways. Okay, Achilles tendonitis. Probably a common thing you guys have heard of. We learned how to tape the Achilles tendon right before we went on a little break here. Cause of injury and inflammation. It's an inflammatory condition involving the tendon. We have repeated stress on the tendon with running and jumping activities and repetitive weight-bearing activities. Signs of the injury are generalized pain and stiffness, especially over the Achilles tendon, just proximal to the calcaneal insertion. So we learned our anatomy where the Achilles tendon attaches right in the back of the heel. Just above that is where you're going to see this pain. And it may progress to have some morning stiffness. Limiting or restricting the activity that causes the initial inflammation, aggressive stretching, and use of anti-inflammatories, and also we've learned the taping to help support that tendon. Achilles tendon rupture, we already talked about the Thompson test to help us find out if this has occurred. It occurs due to a sudden forceful plantar flexion injury, not commonly seen in athletes under the age of 30, usually over the age of 30. Occurs in activities requiring dynamic movement. Okay. Signs of the injury, the athlete may feel or hear a pop. They may also say, hey, it feels like somebody just whacked me in the back of the leg with something. And then you also have a palpable defect where you even have kind of a lump in the calf area because that's ruptured and rolled right up into the calf. Care for these, usually a surgical repair, period of mobilization for 6 to 8 weeks, and then they have to regain full range of motion and normal muscular control, muscular function after that. Pretty significant injury. Okay.